And we are good to go. So once again, welcome everyone to Preventing the Non-Medical Use of Prescription Drugs in New England webinar. We have a great presentation for you today and some wonderful presenters that will be sharing some very helpful information for you as you are continuing your prevention work in New England during this time and beyond when things get back to normal. And so, let me see if I can move forward here. So today we do have, like I said, 3 presenters. And so you'll see that we have Sandra del Sesto, who is a PTTC consultant. We have Megan Hawks and Kim Magoon from the Public Consulting Group here in New England. They will be presenting the data, the New England region data today, and Sandra will be doing the rest of the presentation after the data piece. And the event in which you are about to participate is provided through the New England Prevention Technology Transfer Center. It is a program that is funded through the Substance Abuse and Mental Health Services Administration Cooperative Agreement. You will receive 2 evaluations via email after the webinar has concluded. Both evaluations should take you less than 5 minutes to complete. One is called a GIPRA post-event. And once you complete the GIPRA, you should be automatically redirected to our PCG post-test. If not, you will receive the link that you can paste into your browser. If you fill these out for us, you are helping us evaluate our programs and determine if our services are meeting your needs. And it also lets SAMHSA know if our program is being effective. Some logistics for today. We ask that you please stay muted to eliminate background noise, except during the Q&A period. There will be slides that are prompting you during the Q&A period. We do have some tools via Zoom that I will go over in a minute to help us eliminate any background noise from everyone unmuting themselves at once. So you'll see how to do that when we get to the Q&A period. Instead of just everyone unmuting themselves, there is a wave hand feature. So I'll go over that in just 1 second. We do ask for people to type their name in the chat to help us record attendance. Most of you should have pre-registered, so we should have that in our reports from Zoom. But in case you somehow got through without doing that pre-registration, we just ask that you also type your name into the chat so we can make sure you are getting your participant of, or your certificate of participation. Slides will be emailed to participants after the event, so you can reference those. And like I said, we are recording this presentation, so that can also be shared with you as well. And here are just some Zoom features that I wanted to quickly go over because Zoom is new to some people or a bit unfamiliar. So during the presentation, as I said, please keep your microphone muted. You'll see that you have a control panel where you can mute yourself and unmute yourself, but we are asking you to stay muted. You can start your own video if you wanted to. You can certainly, you don't have to share your video. It is not required. And there is a chat function that you will find in there, and you can also view who's participating today. As I said earlier, there is a function for you to be able to raise your hand if you do have a question for us during the Q&A period. That way we can unmute only you, and we won't have everyone unmuting themselves and trying to talk at once. You can also just type your question in the chat as well, and we will monitor that so we can hopefully answer your questions when that time comes. If you are kind of new to Zoom, you'll see that there are different views that you can see throughout the presentation. You can change it to gallery view, which you see here, so you'll see everyone's faces. You can change it by looking in the right-hand corner of your screen. Or you can just go up there and switch it to speaker view, so you will only see the speaker when they're speaking. So right now it's me, and then it'll be PCG, so Kim and Megan, and then Sandra, and so you'll see just their faces on the screen. Today's objectives are on the screen for you to view. Today we are going to review current data on the non-medical use of prescription drugs in New England. identify risk and protective factors associated with the non-medical use of prescription drugs, define core components of strategies that seek to reduce non-medical use of prescription drugs, describe some of the potential advantages and disadvantages of these strategies, and identify resources that summarize these strategies. And here are presenters that I referenced earlier, just so you can see their faces in advance of them speaking on the screen. They are full of wonderful information, and the New England PTTC loves to work with them, so you are in for a great presentation. And with that, I am going to just take one moment so I can give controls to Megan of PCG so that she can start her presentation. And hopefully, Megan, you have control now. You might be muted if you're talking. All right, I'm just going to take control for 1 second to see what's going on here.
Sorry, Erin, yeah. If you could just take control, that's fine.
Okay.
Having a little trouble there.
No worries. All right, so if you want to go ahead, I will move the slides as needed.
So we'll just be going over some of the New England data, and then we'll explore some risk factors, and then move on to the strategies to reduce the supply, demand, and harm. And then we'll talk about some resources, some wrapping up, and some questions. Great, so we're going to cover some data that we have from New England. We wanted to start by reviewing the prevalence of prescription pain reliever misuse at a national level. You can see here that in the grand scheme of things, New England has comparatively low prevalence, about 2.9 per 100,000 people, whereas in the South and West, it's a little bit higher at about 3.9 per 100,000. I also wanted to highlight the source of this information. So the Behavioral Health Barometer is a great resource that we often use when we want to look at regional trends and comparisons. The indicators are measured through the National Survey on Drug Use, the NISA, as well as the National Survey of Substance Abuse Treatment Services, which provides an annual update on a series of topics that focus on both substance use and mental health in the United States. The report is also intended to provide a concise, reader-friendly summary of key behavioral health measures for a wide variety of lay and professional audiences, and this includes data about the non-medical use of pain relievers, and we'll be sure to put the link in the chat. So,
yep, the link is now in the chat.
Great, thank you. And so the next slide shows the same indicator, but instead of a rate, we're looking at the percentage of those who responded to the survey who indicated yes, divided by the total number of people who answered the question. And so looking more closely at New England, you can see that the percentage of misuse is relatively similar across the states, separated only by about 0.1% in most cases. These numbers can be compared to the Northeast at 3.4% and then to the US at 3.9%. And so just as a note, NISA actually includes New York and Pennsylvania in their Northeast regional estimates. So that's what's bringing the number down a little bit. And so this is the same indicator, which can further be broken down by age group. And so due to small sample sizes, you'll see that it's an average of 2 years. So looking at 2017 and 2018. As you can see here, the non-medical use of prescription pain relievers is more likely among young adults between the ages of 18 and 25. Those middle bars compared to youth 12 to 17, and then young adults that are 26 and older. Substance use in general tends to be higher among the young adult population, and so this is also true for marijuana, heroin, and cocaine. And so really focusing in on that 18 to 25-year-olds, excuse me. We'll be discussing their comparisons in the New England region and the rest of the state shortly. But as you can see here, Maine is the highest at 1.3%, followed by New Hampshire and Connecticut. And then the US and Northeast are part of the lowest bracket at 0.9% and 0.8%. And then this next slide shows among people that are age 12 and older in 2018 who misused prescription pain relievers in the past year, the most common reason for that misuse. And this was due to the pain reliever for physical pain at 63.6%, which is not a significant change from the prior year. And according to the NISA definition, use without a prescription of one's own or use at a higher dosage or more often than prescribed are all classified as misuse, even if it was used for the purpose of pain relief. Other common reasons of misuse were to feel good or to get high, and that decreased from 13.2% to 10.6%, and to relax or relieve tension, and this increased from 8.4% to 9.2%. Less common reasons among past year misusers of pain relievers did not change other than to help with sleep, decreased slightly from 5.4% to 4.5%. The others remain the same. And then among people aged 12 and older in 2018 who misused prescription pain relievers in the past year, the most common source for those last, so it's specifically for the last pain reliever that they misused, was from a friend or relative. And so more than half of the people who misused pain relievers in the past year obtained a pain reliever the very last time from a friend or relative. Specifically, 38.6% of people who misused pain relievers in the past year obtained them from getting them from a friend or relative for free, and then 9.5% bought them from a friend or relative, and then 3.2% took them from a friend or relative without asking. And then more than a third of people who misused the pain relievers in the past year obtained them through prescriptions or stolen pain relievers from healthcare providers, typically getting the pain relievers through prescriptions from one or more doctors. And then about 1 in 15 people who misused pain relievers in the last year bought them from a drug dealer or stranger. And results from these have not significantly changed in the past year. And now I'll turn it over to Kim to present the remaining data.
Sure, thanks, Megan. So we've talked about what kind of prevalence looks like, where the sources are, and reasons why people are misusing. We also need to talk about the prescriber's impact on this. And Sandra is going to spend some time talking about prescriber education as a factor that cuts across supply, demand, and harm reduction strategies. So here we see, this is 2017 data from the CDC, that they are indicating that the prescribing rate for opioids was about 59 per 100. So that's to say that there's 59 prescriptions written for every 100 Americans in 2017. Obviously, that is many, many more prescriptions than people who are actually using prescription opioids. So that's a lot of drugs being dispensed per capita. In 2018, the prescribing rate decreased a little bit to about 51.4. And this is the lowest it had been in about 13 years. The CDC doesn't really have their 2018 data by county available just yet. But as you can see, much of New England from 2017, much of New England hovers on the lower end of that spectrum, with the exception of Maine, or they're kind of in that that next tier up of between 57.2 and 82.3 scripts per 100.
And that's in line with some of the data that we saw before, where there's more misuse and prevalence in Maine than some of the other states.
Mm-hmm. Yep. So to kind of give you an idea about opioid use disorder diagnoses, because that's not entirely the same as prescription drug. We looked at SAMHSA's 2015-2017 data. So, and we specifically look at the data for young adults, for the 18 to 25-year-olds. So this information is aggregated because of the small sample sizes. So we're looking at a few years of data here. These figures are for Region 1 in New England. There you see 1.6% had opioid use disorder within the past year, and then the national average is about 1.3. So the only states who are lower than that national average or lower than the region are Massachusetts and Rhode Island. Everybody else is a little bit above that. But again, we're still talking about single-digit numbers. We're still talking about tenths of a percentage point separating a lot of these states in their opioid use disorder diagnoses. The mortality rate, overdoses per 100,000 individuals has kind of really remained stable over the past few years. So with some variation among states, we can see this is especially true when we look at New England and US numbers. They're really within one here or there for the last 3 years, 17, 18, and 19. They're both very consistent. Unfortunately, New England overdose rate has also been consistently higher per capita than US trends by but it's not just prescription drugs. Can you advance one more? So our finding is that more and more that misuse and overdose are associated with multiple drugs, not just prescription, so polydrug use. And in fact, young adults in New England rank higher than the US average for marijuana use, cocaine use, heroin use, and substance use disorder. So we kind of wanted to give you a perspective of that it is prescription drugs is the focus of this talk, but because this polydrug use going on, it's a broader impact, it's a broader scope. So looking at substance use disorder for those young adults, 18 to 25, we're looking at the map of the US, and you can see that bright spot right over those 6 New England states. So we've listed out specific percentage points for those. About 1/5 of adults between 18 and 25 are reporting a substance use disorder. To put this in perspective for you, substance use disorder for past year for the Northeast has been about 16%. Remember that includes Pennsylvania and New York, so that's kind of pushing that down. And then nationwide, it's about 15%. So all of these New England states rank higher, both in terms of comparing to the Northeast and then comparing to nationwide. Past year marijuana use for adults 18 to 25, same sort of deal. That bright red section right over top of New England. But this time we're talking about 45 to 50% of young adults using marijuana within the past year. So comparatively for the Northeast, it was 39%, and then nationwide it was about 35%. Of course, there's impacts of legalization and all of that as well, but still New England states are ranking higher in their usage. Cocaine use among young adults. Again, New England is ranking right up there. With the this time with cocaine and varying percentages between 6 and 11%. In the Northeast, the average is about 6.8%, and nationwide it's about 6%. So Connecticut kind of fares the best out of this, in lining with the national average, whereas New Hampshire and Vermont are on the higher end of that scale. And then we're also looking at heroin use. So not quite the same monopoly. Heroin use seems to impact the US a little differently than the other substances we've looked at. Not quite to the same extreme, but here we're talking about less than 1% of young adults, 18 to 25. It's still the biggest category of users. And so for the Northeast, we're looking at 0.68% on average, and then for nationwide, we're looking at 0.5% nationwide. So again, Maine almost, well, more than doubles that that national average in their use. We also wanted to talk about some behavioral indicators. Sandra's going to talk about some risk factors here in just a minute, but we want to highlight some of these factors related to risk. We know the perception of harm is a big one. If people think something is harmful, they're usually less likely to do it. But depression and suicidal ideation are also big behavioral factors, and can also make people more susceptible to drug use and misuse. Again, we clearly see that those young adults, those 18 to 25-year-olds, have higher incidence of both major depressive episodes and suicidal ideation, and clearly higher incidence than the Northeast and the US in both cases, with the exception of, go back one please, with the exception of Rhode Island that does a little bit better in that 18 to 25-year-old category, at least for major depressive. So what are the takeaways from all of this data? Overdose is high in New England, like 50% higher than the national average per capita. New England prescriber rates are on par with the national average, but for parts of Maine, they're a bit higher. Self-reported pain reliever use disorder are likely less, or slightly less in Northeast compared to other parts of the nation. But individually, Connecticut, Maine, New Hampshire, Vermont are higher than the national average. And by contrast, those opioid use is a little higher in New England, with Massachusetts and Rhode Island being the only two states that kind of fall below that national and regional average. And then we've also discussed about how people obtain and use their prescription drugs. And we found that most of them obtain them through friends or relatives, whether they were bought, stolen, or given. They're getting them from people they know. And 2/3 of users said that they were using them for pain relief. So using them for the intended use, but misusing how they're being used for the intended use. And then lastly, we talked about the connection between adult polysubstance use and behavioral health indicators of risk for prescription drug misuse. So I think we're going to take a brief pause here to open up for some comments, but I know Megan wanted to also share this key substance use and mental health indicators from the US. This is where some of our data has come from as well, if others are interested. So I will go ahead and put that in the chat as well. Yes. Okay.
Okay, so now we will open it up to questions for Megan and Kim. So I'm realizing I don't see the hand waving function that should be there in the control panel. So if you have a question, oh, it looks like Joanne Joy just proved me wrong. I think she is unmuted, so it looks like Joanne might have a question.
Yes, hi. I'm actually the picture of Mount Katahdin and the Penobscot River. I wonder why alcohol is not one of the chemicals you look at with the polysubstance use.
Megan or Kim, it looks like you're muted if you are trying to answer.
So we were just bringing in some slides just to show some of them. We can definitely get you that alcohol data as well because we do have that data. We're just trying to give those states that the pictures in which New England was much higher than the rest of the United States.
Mm-hmm. And that's not so with alcohol. Alcohol is not also higher, or you didn't look this time?
Yeah, I'll have to, yeah, it's been a moment since I've looked at that particular slide, but I can get it for you.
Okay, thank you.
Okay, thank you, Joanne, for that question. If Anybody else has a question or comment for Kim and Megan, you can feel free to type it in the chat. I am monitoring the chat box, or raise your hand or indicate somehow in the control panel if you have the option that you have a question.
I have a question. When it's the opioid disorders, that graph, those are people with diagnosed disorders that are reported through treatment centers. Am I correct? So it's those who have gone and sought treatment.
Not necessarily of sought treatment. This comes from NSDA data.
Okay.
So that's where they're coming from. They're just
How are they measuring that though, Kim? How do they know?
NSDA data is self-reported, I believe.
Oh, okay, thanks.
Mm-hmm.
And it looks like there is a question in the chat box. Maybe this will be answered later in the webinar, but any ideas how come numbers are relatively high in New England?
I'm not going to be answering that later. I think you need to look at, though, at your own risk factors and protective factors when you do your work through the strategic prevention framework to see what the risk factors are in your area. In some cases, it has to do with the kind of work a person does. For example, fishermen and people who work in tourism usually have higher rates. It could be access. So you would have to look at that more specifically and locally than to look at it in across New England. Our demographics are too different. If you go from Boston to Augusta, for example, too different. So it's better to look at that in a local way.
Yeah, there's a number of other, intervening variables that go into that as well. The overprescribing, especially in New England, was a major factor, as well as the rurality of a lot of the New England states, I think, also adds to it. And then I also saw a question about a way to get the specific numbers for 12 to 17-year-olds. So when we share the slides, you can actually click in and then just or before we send the slides out, we can click in and make sure that all the numbers are there at the top to show those. And then another question for explaining the difference between pain reliever use disorder and opioid use disorder. So I think in 2015, 2016, NSDA, they decided that instead of just calling everything opioids, because opioids typically also include heroin as well, that they wanted to just specifically look at pain relievers.
Yeah, so there's different, they use, the DSM-4 uses different diagnostic criteria to classify opioid use disorder versus pain reliever disorder. So NSDA kind of breaks it out between those two.
And Leanne made a good comment. She said in Maine, it's been said that the higher rates there are due to backbreaking work. And I did work in Appalachia a couple of years ago in 2 different states, and those were coal mining areas. And so it was a combination for them. I often use this example. They were working in the coal mines, so literally they had, back problems. Like in Maine too, access to treatment was, a significant right away, not easily gotten to. And whereas those of us in more suburban and urban areas might have access to non-medical treatments like physical therapy, people who are a distance from healthcare often have, a medication prescribed first, and they don't have access to other kinds of treatments that would be non-medical. And so it leads people very easily into misuse of prescription drugs, and then, on the journey towards opioids that are not legal.
Okay. Thank you for your questions and comments, everyone. Now we are going to go into the next piece of the presentation, and Sandra will continue from here.
So thank you, Megan and Kim. That was really excellent and very helpful. So now we're going to move to strategies to prevent non-medical use of prescription drugs. And what I'm going to be sharing with you is what we know in terms of the latest research on this topic. And as you know, since this epidemic came upon us very quickly, there wasn't a lot of research initially on risk and protective factors. So the ones that I'm sharing with you right now are general, looking at them through national research, and then looking at the strategies that at this point in time appear to be the most effective in reducing the rates. So that's what we're specifically going to be paying attention to. And so first we're going to talk about the risk factors. And Erin's going to move me along as I can't. Right.
Nope,
Thank you.
You just did it.
I did it?
Yeah.
Oh, wonderful. Okay. So we've broken down the risk factors in the 3 categories that you're familiar with based on the Institute of Medicine, individual, friends and family, and community. And so you'll see that among these risk factors, some of them are very common to misuse of any substance. And then some of them are even more specific based on the issue at hand, which is non-medical use. So here we go in terms of individual, and there are a significant number, as you can see. And impulse and sensation seeking is one, and that's in general. Low perception of harm is also across the board, regardless of the substance that you're looking at. Prior substance use is there on the list in general, but it's very, very important here, where you've used, the person has already used, and Megan and Kim spoke to this, other substances, including alcohol, and experiencing, they had a really good slide on this, mental health disorder, because that can be an initiation into substances. If you saw the reasons why people use, it's to relieve pain, relieve tension, and these are often associated with mental health issues. Early onset of non-medical use, and we see that with any substance, early onset of alcohol use or marijuana use. Chronic pain, again, where something, a pain medication is prescribed early on and then stopped without any other options for the person, and then they move on to the improper use of those prescription drugs. So we have, a significant list of individual risk factors. And then we look at friends and family. There are no surprises here. So obtaining drugs from family or friends, and you saw that in the data that Kim and Megan presented. Improper storage and disposal of prescription drugs. And that was also in the data they shared. The way folks are getting them is through family and friends, often where it's given to them. Lack of awareness of the risk factors associated with opioids. And then here's a common risk factor association with peers that misuse. And then finally, at the community level, access to illegal pill mills, places where these drugs are easily available, and that includes online. And then low utilization of a prescription drug monitoring program. I think all of our states have them in New England, but they are not often required. There's no censoring of doctors who aren't using them, or they're set up in such a way that they are cumbersome for physicians to use, and they don't use them, which is unfortunate. In my state, for example, initially only doctors could enter the data, and they said, typical of doctors, and I have a number of them in my family. It's like, it takes too much time. I don't have time for that. So when they added the ability for a staff person associated with that physician, a nurse practitioner, or a designated medical assistant, then the utilization went up. So the legislation is worth looking at to see whether or not, and you need to check, nothing about us without us. Check with the physicians in your state to see what would make that drug monitoring program more acceptable to them. And then obviously something we've talked a lot about, overprescribing by physicians. And so those are the risk factors that have the most data attached to them in terms of the research. And now we're going to move on to the protective factors. Okay, and we'll do the same thing. The individual protective factor is singular here, having a greater perception of substance misuse and abuse risks. So educating individuals about the risks attached is extremely important. And then in the next category, the first one I think is interesting, a commitment to doing well in school. And that is achieving high school and college degrees are actually protective factors. Having parents who disapprove of youth, and having a strong parental bond. I don't think any of those would be surprising to you. And again, the latter two here are common to all substances, and I'm sure you're familiar with them. But now here, in terms of protective factors, and this is really important for us who work in prevention, there are actually 5 that are highlighted in the research. One of them, the one on the top, might surprise you, but maybe not. And that would be the presence of a gay-straight alliance. We do know that LGBT youth and young adults are at more risk for substance misuse. And so having a support system is particularly important. Community norms, no problem. Or no surprise. Attending an evidence-based prevention program, no surprise. And I was asked last week about a program that's very popular in a state, not in the New England area, but it's only knowledge only. So, and the research on it is very poor, and yet it's being embraced by an entire state. So that's unfortunate. So we know that it has to be knowledge plus skills in order to really be a strong program. So the next one is important, only prescribing Schedule 3 or 4 opioids with no lower misuse or abuse level. So looking for alternatives that don't have the significant adverse side effects, that would bring people to addiction is really important. And that's certainly an issue of education for physicians. Most of the time, physicians are not educated. If they take one course in all their pre-med and medical school training around substance misuse and abuse, that's a lot. So they may need education around that. And then finally, prescribing a long-acting opioid, believe it or not, is associated with lower misuse, abuse, and dependence. And that's research that was done actually about a decade ago, but seems to be holding up over time. So again, if you have any questions about any of these, just kind of take a note and we'll address them later. Okay, so now we're going to talk about desired outcomes. So our outcomes, if you look here, is obviously decreasing availability, preventing dependence and misuse, and reducing non-fatal and fatal overdoses. And those outcomes can be categorized in 3 areas that are not unfamiliar to you. One is to decrease the supply, decrease the demand, or engage in harm reduction strategies. I always like to comment that when I first started working in prevention, we couldn't even use that language. But then when we got into the HIV and AIDS epidemic, harm reduction was very important. Condom use, meal exchange programs, just teaching people how to clean needles. All those were harm reduction strategies that had a significant impact in reducing rates. And so now with the opioid epidemic, we're also now engaging in a lot of harm reduction strategies, sometimes to the detriment, I think, of supply and demand, but that's my own personal opinion. So given those outcomes that we have, those 3 outcomes, we have specific strategies that I'm going to talk about in a minute, and the risk factors that are associated with supply. And you'll see prescription drug diversion, multiple prescribers, where people do doctor shopping, and inappropriate prescribing. Under demand is lack of knowledge, mental health disorders, and chronic pain. And then harm, it's loss of tolerance. So people need more, and polysubstance use. So I do see a comment here by Jean. I've read that gay straight alliances help reduce substance use among middle and high school youth. So do gay straight trans alliances is there research to show similar protective factors? The answer is yes. Good comment. Okay, so now we're going to talk about strategies. This is now the research. And we're going to separate those strategies into 3 areas. Strategies to prevent demand, to prevent supply, and to prevent harm. Okay, and whoops. I'm going to go back because there's information that's not coming up on the slide that I'll share. Actually, so there's a number of strategies across each one of these, and actually I'm going to be sharing them one at a time. But you'll see. Okay, I'm going to go back. Okay. They overlap, you know, remember the spiff flowers. So there is an overlap. For example, there are prescriber education strategies that are intended to prevent or reduce supply, to reduce demand, and to reduce the harm of prescription drugs for non-medical use. So a prescriber education would be right here in the middle, because you'll hear it from me going forward, that it actually fits into every one of these strategy areas. So, and we also need to know that the effective implementation of one strategy can have unintended outcomes, particularly when trying to address supply and demand. For example, by reducing the supply of prescription opioids for non-medical use, individuals with a prescription drug dependency may turn to heroin because it's easier to access. That's something that you know about. So we push it down on one place and then it pops up on another. So I like this slide. This is about reminding ourselves that we can't put the cart before the horse, that we actually have to engage in the strategic prevention process in order to do a good job. So as I mentioned briefly before, you know, our assessment in the community where we look at, what the specific problem is, what are associated issues. And someone mentioned alcohol, but it could be the use of, and we're seeing a lot of methamphetamine and cocaine use increasing because people are using it, to bring them up when the opioid use brings them down. So that's really important. And then looking, as I said, at the local risk and protective factors, and then building the capacity in the community to respond, to the problem, and also looking at the resources and readiness. Again, this is all information that those of us who are familiar with the strategic prevention framework and the substance abuse prevention skills training, there's a lot of discussion about that. And then, of course, we have to do our planning, which means selecting the best intervention related to the risk factors, implementing it with fidelity, and doing our evaluation, which of course, begins in the assessment phase. And then looking at ways where we can sustain the outcomes and using culturally competent strategies. And so, what might work with rural loggers in Maine, it wouldn't necessarily work with people who are in casinos in Connecticut, Massachusetts, Rhode Island, or, all of our other states now. I think we all have casinos. It's just an example that I'm wanting to give you in terms of contrast. So if we're looking, again, thinking about the strategic prevention framework, we're going to first ask specifically, what are the non-medical use and prescription drugs problems in our community, and then second, what community stakeholders need to be on board. And of course, one example is physicians, but it would also be dentists, as you know. I'm sure you've thought about this before, physical therapists, anyone who's working with someone who has, say, a mental health disorder, another substance use disorder, or is dealing with chronic pain. And there are probably other categories that I'm not mentioning. And then look at the local risk and protective factors associated. Now you can look to your state epidemiological outcome work group, which would have identified risk and protective factors specifically for this for your state. And that would be the best place to begin. And then looking at it in terms of what's the highest priority. And that might change by region to region in your state. Okay, so we're going to first talk about the strategies to reduce the demand for prescription drugs. And so, and we're going, those are efforts to reduce the public's desire for prescription drugs. And we can move to the next slide. Thank you for doing that for me. Okay. So there are 4 categories in this demand reduction strategy area. And the star is in front of prescriber education because you'll see that it's common to each one. So if we look first, okay, we're going to talk about patient and prescriber education. So findings from a systematic literature review note that the quality of evidence for the effect of patient education programs, believe it or not, folks, is moderate to low, okay? Patient education strategies involve providing patients with information on overdose, potential of prescription drugs and their effects, the importance of safeguarding prescriptions, and the risks and benefits of a particular drug. Prescriber education, on the other hand, as you would imagine, involves teaching prescribers about the benefits and risks of prescribing opioids. So first, making them aware of best practice guidelines, how and when to implement tracking and monitoring strategies, and probably most important, identifying, sharing, and encouraging alternative pain management strategies. So we still must mention the importance of maintaining legitimate and appropriate access to opioids. I mean, people with chronic pain, particularly after surgery, and I'm sure there's a number of you here that have had surgery and been very grateful for an opioid prescription when you were in the hospital. We can't negate that. And actually, the beginning of the opioid epidemic, there were a couple of factors, but one of them was when we became aware as a culture that people were being under-prescribed pain medication. So now we know when we go, into the hospital or into an emergency room, they ask people to rate their pain from 1 to 10. You've probably been asked that question at some point if you've had an injury. And then encouraging prescribers, to work with the patient so that they can reduce that pain level. So that has led in the beginning to prescribers being more willing to prescribe opioids than perhaps they were in the past. So let's talk about, for a second, best prescribing practices and guidelines. And we can send this information out to you later. CDC has guidelines for prescribing opioids for chronic pain, and many states have developed their own. So one state, for example, Washington State, has guidelines that they've promulgated to their healthcare providers. And in just doing that, this was associated with a decline in average in use. So in the average dose of long-acting opioids, okay, and ultimately fewer opioid deaths. So one of the questions that I would ask you is, does your state have prescriber guidelines? That would be something that we could advocate for as prevention providers. The second thing we want to think about is how and where do we implement our tracking and monitoring strategies. So a little more research in Utah expanded prescriber education programs focused on recommended practices and using the state's prescription drug monitoring program. And that kind of education was associated with a 60 to 80% reduction in inappropriate prescribing habits among prescribers. So making sure that that PDMP is up and running, that it's being used, that it has ease of use, actually has excellent results. And the CDC guidelines that I mentioned offers recommendations about alternative pain management strategies, as do some of the state developed guidelines. So consider that, put that on your list of something you might want to think about and check on. Okay, so the second demand reduction strategy that we would talk about is information dissemination and social marketing campaigns. And we've all seen them, and many of us have participated in them. But although they're common, from the research, few have been formally evaluated for effectiveness. So there is some data about the efficacy of social marketing campaigns, but it's still limited. And one study found that it does help increase the perception of harm. And the techniques, of course, have been adopted from commercial marketing. And the messages usually seek to influence community attitudes, minimize the perceived negative consequences associated with behavior change. So minimize the negative consequences. That would mean that, the negative consequences of reducing or eliminating use of pain medication is minimized, and other things are suggested. So social marketing campaigns were also found to be associated with the greater likelihood, this is a good thing, of parents reporting intentions to control the supply of prescription drugs in their home, which is a supply strategy, and a decreased unintentional overdose deaths from prescribed opioids. So there is some association, but right now there's not a whole lot of research attached to this in terms of effectiveness. And it's really, again, as we know in our prevention work, that this is a universal strategy, and unless it's coupled with other things, it's unlikely to have a long-term positive impact. Okay, so we have a poll for you. And Erin, it's not showing up on my screen right now. Okay. Oh, here it is. Okay, I'm hoping everyone can see this. So the question is, which demand interventions in your community are you implementing now? Oh yeah, it's working. Okay, wonderful. All right, you just have to, you can click on more than one. Excellent. Okay, nice job. All right, so if we look, information dissemination, 88% of us are doing this work. Now, if you remember, we're going to talk about this in a little while, the tri-ethnic center model for change. Information dissemination is important, but it's up there with one of the earliest steps in terms of behavior change in at the community level, with low awareness, denial, or no knowledge, of the program. So we do know that most of us are well aware of the problems with the opioid epidemic. So while it's important to continue to provide information to folks, we really need to begin to think about, and I'll say this more than once, more sophisticated strategies. And so prescriber education, let's see, the second one is social marketing, again, a universal strategy. Those two are. And then we get down to prescriber education. That's great, because that's one of the strategies that has the most impact and the most positive data around it. And then patient education, which is good, but the research is telling us that it's not as effective as the prescribers. Okay, that went quickly. All right, so we'll wait next time. We'll be a little slower about it. Okay, but you could make a comment if you wanted by unmuting yourself. Or we can wait till the question and answer period. Okay, so now
I have a comment. Robin Cox at Connecticut Department of Mental Health and Addiction Services. So we use all of those strategies when working with our coalitions and our nonprofit agencies and the regional behavioral health action organizations. So I just wanted to chime in and say that.
Okay.
Collectively, it takes a multiple prong approach to move the needle.
Great. Okay, good point. We'll talk more about that in a little bit. So now we're going to talk about the strategies to reduce the supply. We just talked about reducing the demand. And so we'll go further here. All right, and there are 5 supply reduction strategies, and we'll talk about them one at a time. And once again, you see prescriber education coming up because it's, from the research, the most effective strategies, and that it, as I said, it addresses all 3 categories. So we will talk about them one by one. So tracking and monitoring, we've already mentioned. And many states have them, but not all mandate participation. And so that would be something that I'd want to look at in my state to see if it's mandated. That ask about the compliance level, whether there's a sanction for non-compliance for docs, And this can be used to identify prescribers or pharmacies who are dispensing substances in excessive quantities, or individuals engaged in doctor or pharmacy shopping activities, and doctors who are obviously overprescribing. So compared to states without prescription drug monitoring programs, those that do have shown reductions in the supply and abuse of opioids and drug abuse and misuse. No surprise there. So if you look down here too, we talk about the program itself, but also prescriber and patient requirements prior to prescribing or dispensing prescription drugs. So what are we asking of our prescribers, and what are they asking of their patients before they prescribe? In addition, to what are the drugs they're using, but also if they're experiencing a mental health disorder, for example. And the second, nothing that you're not familiar with again, is our enforcement strategies. So now they rely on the support of police officers and law enforcement, and we have retail access restrictions enacted by federal laws, state laws, health insurance companies. So in my state, Rhode Island, recently they passed legislation that limited the amount of opioids that could be prescribed at any one time, and that was dropped from 30 to 10. That was very interesting. Some doctors were opposed to it because it took the control of the prescribing away from them. And some of them complained to me, that they have to go back. If they wanted to prescribe 30 because they were needed, they have to go back to the insurer 3 times, to get a greater number of prescriptions. So these strategies, all of them, involve the involvement of policymakers, since they involve changes in laws and or regulations. So there's another resource that we can share with you later, and it's about a training guide for teaching law enforcement about using their state's PDMP. And it was intended for use by a state's administrator, but can also be used by anyone who has the knowledge of how a prescription drug monitoring system works. And Purdue, which of course has been sanctioned recently for other reasons, has been involved in prevention because they have a good website called RX Safety Matters, and we can send that one to you also. So now we're going to move on and talk about storage, proper medication storage and disposal strategies. Okay, so you might be surprised to hear that no evaluations have found a relationship between take-back programs and rates of misuse or abuse of non-medical use of prescription drugs or opioids. So, and I just saw something online that SAMHSA is going to do again in a different way, a take-back strategy. This is really a public awareness strategy, but if this and social media campaigns and information dissemination campaigns are all you're doing, it is unlikely that you, according to the research, that you will be able to change any rates in your state or in your region. So I think that's new information. It was a surprise to me, but it's very important that we know this. However, we can talk about the importance of safe storage. And if we go back to Megan and Kim's presentation, people get these medications from family and friends. Either they're given to them or they take them. So safe medication storage is still a very important strategy. And disposal is important. I can see the importance of it, but the take back programs, again, have no data that says that they will impact on rates. One study did find that individuals who received a pamphlet about safe medication, that it didn't improve their opioid storage behavior. So giving people information without following it up with something more than that is unlikely to impact their behavior. But there was another study that said when people keep the medication in a safe place, that does actually help. There's a project called the Harmful Legal Prevention Product Project. I think I have to say that 10 times fast. Harmful Legal Prevention Product Project. All right, it's from Think Smart, and it's an adaptation of the Life Skills Training Program. That's a possible program that that you could look at. So now we're going to go to another poll. Oh, okay, I'm going to talk about this in a minute. Can we go to the poll, Erin? Oh, I can see it. Okay. Give me a second, folks. Okay. So if you could, and we'll give you a little more time, which supply interventions are your communities implementing now? Okay. All right, now if you have other, you could type it in the chat box and share it with us. Wonderful. Okay, so we see once again, storage and disposal is the most popular intervention. And I'm really happy to see that prescriber education, which as I said, has the best outcome data attached to it, is coming up second. And then retail access restrictions, important, tracking, they're all important here. And they all have pretty good data around it. I'm looking to see, okay. All right, thank you very much for that. All right, let's go out of this. Okay, so I asked Erin if she would include this slide for us. This is from the Substance Abuse Prevention Skills Training, the SAPS, and it's, I always say to folks, it's one of my favorite handouts from the Tri-Ethnic Center. Not only described the 9 stages of, go to the next slide, show you the other, all right, the other 3, all right, it has 9 stages. And in that strategy list, they identified the best strategies based on what stage your community is at. Now, what I'd like to propose to you here is that most of our communities now are beyond stage 1, 2, and 3, and maybe even 4. So if that be the case, then it doesn't make sense for us to stay with strategies that belong to an earlier stage. That doesn't mean we can't continue them, but if we're putting all of our energy and all our funding into these kinds of strategies and not into strategies that are better at stage 5, which is preparation, where communities are getting ready, and most of us are beyond that. But educational outreach programs for the public, for community leaders, and we have media there. But then look here, so it's in-service education, And that would be not only for prescribers, but a broader group of prescribers beyond physicians. I could be nurse practitioners, physician's assistants, dentists, but it also would include non-prescribers, but people who are working with pain, such as physical therapists, okay? And then institutionalization, and a lot of that to me is policy work, which with this particular agenda is very important. And then moving on to in-service education programs about evaluating, sharing evaluation data with key folks, and continuing in-service, etc. So think about that in terms of where you're putting your energies, both at the state, regional, and local level. And so the third category that we're going to discuss is strategies to reduce the harm, or harm reduction strategies. And this is where, you know, the federal government has been putting, you know, a lot of money, and you know, it is prevention. So we're preventing death here. We're preventing overdose. And there are three categories, and here's prescriber education once again. So we can, and then overdose prevention, and then naloxone education and distribution. So now in Washington State, we just want to talk in general about prescriber education, actually, before I go to the slide. And so in this category of harm reduction for prescribers, we would be educating them about how to recognize when an individual is at risk for non-medical use or overdose, when and how to refer patients to treatment services. And I found this in my own state, that physicians often do not know who is appropriate to, besides local treatment agencies, but which other therapists, for example, have training in working with folks who have a substance use disorder, and which providers would be able to work with someone who has a disability, for example, is non-English speaking or has limited English proficiency, or is a gay person that may want to be with someone who understands their lifestyle and how, you know, how the difficulties that they experience in the community. So that's important. That's a kind of education that you can assist them with in terms of resources. And then teaching physicians about how to use the PDMP to identify polysubstance use among their patients, and then strategies to prevent overdose. So in Washington State, optional opioid prescriber educational guidelines, they were optional now. They were associated with a 27% decrease in the number of workers on disability compensation who received an opioid prescription, and a 50% decrease in overdose deaths among those individuals. So these were prescriber educational guidelines that were developed, and they had those very significant outcomes. And in Utah, they had an expanded prescriber education program, and that was associated with a 14% decrease in medication-related overdose deaths and a 60 to 80% reduction in inappropriate prescribing habits. So prescriber educational guidelines, and that can be, you know, not only distributed to physicians and other prescribers, but also, you know, they need CMEs all the time and continuing credits, and that could be offered to them by your agencies. So now we can talk about the other two. naloxone education and distribution, we're all very familiar with. We would, it informs prescribers and dispensers here, also potential first responders and the broader community, which would include family members and friends of people who have a substance use disorder, educating them on the appropriate use of naloxone and the opportunity it prevents to save a life. So overdose education involves teaching groups close to the problem, as you would expect, how to prevent overdoses from occurring. So while there isn't any comprehensive evaluation of naloxone programs, but we do know that naloxone has reversed thousands of opioid overdoses over the last 10 years or so. There have been 62 different evaluations where the program achieved other changes that may result in future successful reversals, such as the significant number of people trained or on recognizing an overdose and administering naloxone. So we're increasing the number of folks who can respond to an overdose in the prescriber community, but also in the community at large. And that's something new. So in many of our states, we have naloxone easily available to folks. Okay, so now we're going to a last poll. Okay, Erin, can you bring that up? I'm having trouble. Okay, here we go. This is our last poll. And we're wondering, of these harm reduction strategies, which ones are you implementing? And now you can indicate, aha, see everybody, naloxone education, overdose education. All right, so again, we've gotten a lot of encouragement to do this. You know, this is further up the continuum. You know, we're preventing overdoses and deaths. That's really important. But if we, you know, cycle back to more primary prevention, that's where we're working on supply and demand. So these are very important. And I like to see here prescriber education on this list, and to see that 66% of you are involved in that as well, in addition to first responder education. So thank you for that. Okay. So here are the results, and naloxone education, no surprise, is the most significant. Okay. All right, so now we're just gonna spend a little bit of time talking about developing a comprehensive approach. So we know that the strategic prevention framework is something, a process that we have to adhere to. I've already referenced that, and I hope I don't need to convince you, I'm sure I don't, of the efficacy of this process. However, sometimes I think we have to spend a little time convincing the community, and sometimes even our funders, about the importance of doing our assessment, building the capacity, and spending time in the planning phase, because there is an urgency in our communities to address this issue. But if we don't, my dad used to say, pay now or pay later. If we don't do that upfront work well and comprehensively, then we're not going to be able to affect any behavioral change, which is, you know, definitely our goal. So here's an example of a comprehensive approach. So in the assessment phase, any town would identify these two risk factors as the highest priority: lack of knowledge about the dangers and inappropriate prescribing and polysubstance use. And that was mentioned by Megan and Kim earlier. And so I'm going to jump you over. So the outcomes are, as you can see, we're going to move from here to here, is preventing dependency and misuse. Inappropriate prescribing, our desired outcome would decrease availability. Locking up prescriptions would also have this the same outcome. In polysubstance use, we want to reduce fatal or non-fatal overdoses. And then, you know, we identify the risk factor, we identify, these are actually in short-term or intermediate outcomes, because the long-term outcome is reducing the rates. And then the strategies, as in any logic model, would be linked to these risk factors that were specific to my community. And as you can see, they work really well. Okay, so I'm going to turn it back over to Erin.
Thank you, Sandra. So we are going to open it now to the Q&A portion of the webinar. We have a little more than 30 minutes to focus on this. So if you would like to ask a question or have some comments or final thoughts, please go ahead and send them into the chat, or we can try to get you unmuted so you can go ahead and ask it over the webinar. I believe you should be able to unmute yourselves. If not, you could try raising your hand if you have that option, or indicating in some way that you would like to speak. You can also just enter your question into the chat.
Gee, if we don't have any questions, I'd like to ask you a question. If you could put in the chat box, oh, here's a question. Is there one publication to use for the Tri-Ethnic Center's community readiness? The best thing for you to do is to go on the website, just Google Tri-Ethnic Center Stages of Readiness. They actually have a wonderful, wonderful, wonderful tool that you can use in terms of building capacity, first identifying those sectors of your community and their level of readiness, and then helping you determine the strategy that's most appropriate for that sector and how to implement that strategy. So it's also a link that we can send you, but you'll be able to find it online, and it's a free tool, so you can take advantage of it easily.
And I have some questions that came through privately and not the group chat. So we do have someone who would be interested in a few study citations that indicate GLBTQ Alliance student clubs functioning as a specific protective factor. So Sandra, I don't know if there's anything that you can share with me that I could share with the participants, but I'd be happy to send that information out.
Okay, I will get that to you, and then you can move it forward.
Okay. And then I do have another question. Do you know of any research studies being done on the effectiveness of drug disposal, e.g. take-back days? Is part of the reason there is no research demonstrating on effectiveness because it is relatively new? No,
And that it's not because it's new, because it's one of the older strategies. It's just that it's been found, it does increase awareness, but it's not linked to a long-term outcome of lesser use. And again, if there was any surprise to me in looking at the research, that was it. So once again, you know, it's in my mind, it's it's an awareness strategy. I don't think, but to spend all your time and effort on that and funding would probably not be as effective as some of the other strategies. But there've been a number of studies done, and none of them are indicating that there's any change in rates.
Okay. And a question from Leanne Dodge. Does anyone have materials specifically for veterinarians? So I think if Sandra has any, obviously we would want to know those. And if anybody else on the webinar has come across anything and you would like to share those, you can certainly email them to me and I can get them out to the group. Sandra, did you hear that?
Yes,
Okay.
I wrote it down. That's that'd be new to me. I actually had read some information about that, but I think we can find something. And we do have I think we have some resources listed at the end of the training, but if not, I will definitely get this to Erin. Plus the suggestions for some materials that you can download that might be useful in your work.
Okay. And it looks like we just have a comment from someone. It still surprises me that educating MDs is one of the most important strategies. You would assume it is part of their formal training. And Sandra, I know you touched upon that during your presentation.
Right. I'm here near the Brown Medical School. They have one course in the course of 4 years in the med school. I have a number of physicians and dentists in my family, 7 in my extended family, and none of them took more than one course in their education around this. So it's really quite unfortunate. So even though we assume that they're experts in this area, there's a wonderful opportunity we have to not only provide them with education around this and even more awareness, but also where to go, how to recognize, which, believe it or not, is not something that they've ever been taught in many cases. So there are great opportunities here. So, but we can't assume that they know because of all the tremendous education and even their rotations and their residencies. That's not one that's required. So, there is something lacking there.
I think part of the discussion too when it comes to education for physicians also is educating them about what prevention is and what primary prevention is. And also letting them know that, it's a community issue and not just an issue that people are approaching physicians for, and that, we're here to help.
Good point. And having them see us as a resource. And I think I'm just adding to what you said, but sometimes they don't even know we exist. And your community hospitals have to have a community group that looks at priorities, and so you might check into that. We always say if the mountain will come to Muhammad, Muhammad can go to the mountain. And so that's a group you could join and share information with. And often groups like that don't have strategic planning skills, and you bring that to the table as well. So you would be more than welcome at any of those tables. Also, there are physicians organizations in your state, and many of them have behavioral health committees. I did that in my state. I asked to join the behavioral health committee because I couldn't get a doctor to be on my advisory board when I was working on this issue at one of our colleges. So I joined their committee. So that's a suggestion I would also have for you. Okay, and you know, I'm just looking at my notes again. So believe it or not, there were no evaluations that have found a relationship between take-back programs and rates of prescriber drug misuse or abuse. And the sources of that are the Department of Enforcement Administration, 2 citations from them, actually 4 different citations from them on terms of the evaluations and what they showed.
Okay, so I do have another comment that came through from, I'm gonna probably not say this right, Josefina Mendoza. I am the new SUD PMA in Alameda, Solano, and Contra Costa counties, and I would like to know if there are any other trainings for me to take in order to help my patients.
Erin, are there trainings through the PTTC?
So there might be trainings through the ATTC,
That's what I was thinking of.
the Addiction Technology Transfer Center. And what I can do is I can take that question to them and ask if they have any recommendations and share those out to you. Specifically, I should have your email via registration and I can make those available and also send you a link to the ATTC if you don't already know about that organization. All right, and just to reference another question, I am going to share these slides via email at the end of the presentation today, so you will get a copy of those. And then I do have someone who would like to be unmuted to just make a quick comment, so I will go ahead and unmute that person now, Leanne Dodge.
Hi, everyone. I just wanted to make a comment about having, trying to get pediatricians on your coalition. So if you do coalition work, we have a great pediatrician on our board. And so that's been really significant in educating her. Like Sandra was saying, my brother's a pediatrician in New York. I have a nephew that's a doctor, and I definitely agree there's not always a ton of substance use education in their medical training. But our pediatrician has been such a great advocate and also giving materials to parents during the well child visits where the parents don't come in anymore for that child visit, you know, when they're like 13. And we have a large youth subcommittee in our work with about 70 high school students, and they go down to the middle schools and talk about substances to the middle schoolers. And one of the patients of our pediatrician on our board, she met with this 8th grader and she said to her, hey, are you getting excited about going to high school next year? Are you nervous? You know, and the patient said, no, I heard there's some group up at the high school, so I'm not worried at all about this stuff. So I think that's the other thing, is to know that there's all these sectors can cross over, and having youth and, you know, physicians on your coalitions can be really helpful in doing that education piece. Thanks for letting me talk.
Thank you, Leanne.
Thank you for saying that, though. That's terrific. You know, and sometimes it just necessitates an introduction, or you may be going to your own primary care physician and pediatrician, and if they say that they're too busy, maybe it could be the nurse practitioner in their office, or it could be someone who's on the senior staff of the physicians organization in your state or region, or maybe another physician that, you know, might have some time. But you want to pick someone who has access to other folks in their field, you know, where they could have an impact, rather than someone who is not active with the Physicians Association or whatever. So I saw Joanne Joy raised her hand.
Yes, I had just, first of all, thank you very much. This was helpful. And I noticed that there's no, I went on the site for the Triethnic Center and see that this handbook is no longer being supported by them. Are there other resources for going through the process of assessment, et cetera, that is referred to in their book, in their handbook?
Erin, could you hear her?
Joanne, you were a little hard to hear, but it sounds like you didn't find something on the Triethnic website, so you were looking for other resources. Is that correct?
They no longer have any technical assistance.
Okay, they no longer have that technical assistance.
Who else can help with it?
Who else can help?
I don't know. I'll have to write myself a note on that also. I don't have it downloaded, but I could see if someone else does, or if I can locate it. So I'll look for it, Joanne.
Okay, thank you, Joanne, for letting us know about that. Okay, I'm not seeing any other questions, but I do have a comment, a recommendation from Peg. I don't know how to pronounce your last name. I apologize. Saladay. The Scope of Pain program is an education program for physicians that is excellent on educating MDs and medical practitioners on prescribing practices. Not sure where it originated. Boston University Medical Center, maybe. It's a great training. So I can do a little digging into that and include that in the list of resources that we will share with you after today's webinar.
Thank you. Sorry, I was just trying to unmute myself.
Oh, that's okay.
We provided that for a regional coalition on the North Shore in Mass. I just can't remember who originated the training. I think it was BU, but it was a fabulous program for physicians and nurse practitioners. It was really, really good, current, up-to-date information. I learned a lot. It was one of the better trainings I've been to in a long time.
If you could share that, that would be terrific.
Yeah, I'll see if I can dig it up.
Thank you very much. Okay, I'm not seeing any more comments. So with that, we'll move along. This screen has been up, so you've probably seen it, but for more information on this topic, you can visit the National SAMHSA website and also the Prevention Technology Transfer Center websites for more opportunities for prevention trainings and resources. And you can also find the links to the other technology transfer centers. There's the Addiction Technology Transfer Center that's been around for about 25 years. And there's also the Mental Health Technology Transfer Center, which was established the same year as the PTTC in October 2018.
Can I ask, remember Erin, you just said to me, did you get that, Sandra? And I said, yes, I wrote it down. But now I looked at my note and I don't know what it was. I put vets. Oh, veterinarians.
Yes.
Not veterans. Okay, got it. Sorry.
That's okay. All right. So if you do have any questions or comments on this webinar and the content that we overviewed, or have questions for PCG or Sandra specifically, please don't hesitate to contact me. I am the Training and Outreach Coordinator for the New England PTTC. You can see my email address on the screen. And as I said before, we do have a lot of great resources, not only from the New England region, but from other technology transfer centers in the country and some of our national centers as well. So there is just a great host of resources that you can access on the TTC network. And in the chat box, my lovely coworker, Sarah Johnson, just posted the links to our GIPRA post-event survey that should hopefully redirect you to the PCG post-test. If not, you will also get that link. But if you could take a moment to fill those out for us, we would greatly appreciate it, as it does help inform us in the work that we do, the resources that we provide you. And it also lets SAMHSA know if we are effective in our implementation of the strategies that we have identified. And so with that, I'm just going to share some of the references with you. I'll go kind of quickly through them, but you will receive these in the PowerPoint slides. So there are quite a few pages, as you will see. And with that, I would just like to thank everyone for joining us today and for providing the wonderful comments and questions throughout. This was a great presentation, and I really love that you were all interactive and responsive in asking questions and providing comments. That was really wonderful. So thank you again. Enjoy the rest of your day, and I hope you all enjoy the rest of your week as well.
Don't forget to fill out your evaluation forms.
Yes, please. I will email them out as well, along with your certificates of attendance and the PowerPoint.
And some resources.
And resources. Thank you, everyone.